So, can we cure HBV with direct-acting antivirals? That's the topic of the day. So, as you know, I mean, we are trying, and that was well introduced by the previous speaker. We are trying not to develop new treatments so that we can have finite duration therapies that would lead to a functional cure, which is defined by the disappearance of HBs antigen in serum associated with a decline and a control of cccDNA in the liver. And this is really the main goal nowadays for the new therapies that are being developed. Obviously, there are other goals that are more ambitious, but including complete cure and sterilizing cure, but we won't discuss this today. So regarding the barriers to functional cures, they rely mainly on two aspects. One is the one of our factors, and mainly the persistence of the cccDNA reservoir in the infected hepatocyte. And on the other hand is the fact that we have to face a defective immune response against the virus. So, and this leads to the persistence of the virus and really makes the treatment difficult in terms of eradication of the virus. Now, what we have learned from long-term experience with nucleoside analogs, and this was well summarized previously, that despite our clinical observation that viral load may be suppressed by nucleoside analogs, actually the virus persists in the liver and mainly cccDNA. And you see here one study with sequential biopsies in patients who were treated for long-term with tenofovir, showing that the decline of cccDNA is very, very slow, despite years of administration of tenofovir. And at the same time, you see that the HBs antigen level are clearly plateauing in these patients. And based on mathematical modeling, it was estimated that new round of infection or replenishment of the pool of cccDNA occur despite this so-called viral suppression that we see with the quantitative PCR monitoring. And there was a more recent studies that were presented at the EASL earlier this year by the Gilead group, where they look at the tenofovir trial experience, and they realize that in most of the patients who have HBV DNA under the limit of quantification, you can find viral DNA detected. So this is what we call target detected but non-quantifiable viral load. So they were interested to see what is this residual viremia. So they took the serum from these patients and they inoculated the serum sample to humanized mice with a humanized liver. And what they found is that these serum samples are actually infectious in the mouse. So this indicates that this residual viremia is really an active virus that can infect new hepatocytes or new livers in that case, which may be a way for the virus to persist despite long-term nuke therapy. So we have here, it really shows that we have place for improvement with the current drugs if we want to achieve cccDNA clearance. So how cccDNA steady state is maintained is it's a balance between synthesis, so synthesis of new cccDNA molecules by either de novo infection of new cells or by recycling of viral DNA within the infected cell to the nucleus. And this is a balance between synthesis and elimination that can occur naturally, either by non-cytolytic cccDNA elimination or by hepatocyte turnover. Now, if we want to switch the balance towards elimination, several strategies can be envisaged. Either try to increase the rate of infected cell death and or to increase the rate of non-infected cell division, but this is really something that I would not advise because dealing with an oncogenic virus, stimulating a cell proliferation wouldn't be a good idea in terms of oncogenic process. Now, what can be realistically done is trying to decrease the replenishment of cccDNA with better viral suppression, or to directly eradicate cccDNA from the infected cells. So currently, we have mainly drugs that have been evaluated in preclinical models and now in clinical trials, phase 1b, phase 2 studies. And the current landscape is very exciting. So most of the drugs are actually targeting pre- and post-cccDNA steps of the viral life cycle. So they are mainly entry inhibitors, drugs targeting viral transcript, capsid assembly modulators. Obviously, we have already the polymerase inhibitors, and there are some inhibitors of HBs release. So drugs that are more ambitious are drugs that are trying to target directly cccDNA for degradation or silencing, or to target HBX with the aim of curing hepatocyte. And these approaches are mainly in preclinical development nowadays because this is much more challenging. Not to forget that the infected hepatocytes are in a liver environment with immune responses, and the enhanced suppression of viral replication or viral protein expression may lead to modification of this liver immune environment that may be beneficial in terms of antiviral therapy, whether we are dealing with direct acting antivirals alone or in combination with immunomodulatory approaches. So let's see what we have now currently in these strategies trying to better suppress viral replication and control the pool of cccDNA. They are entry inhibitors, and these entry inhibitors have really been developed thanks to the discovery of the receptor of HBV, NTCP, and the main drug that is in development is Mircludex. And as you will hear later in the conference, this drug is mainly developed for hepatitis delta currently. For HBV, we have really a lot of research efforts regarding capsid assembly modulators that were historically divided or classified in two main classes. The first one is the heteroaryl dihydropyrimidine family, which lead to the formation of aggregates and aberrant capsid structures. And the other class is mainly, in terms of chemistry, of phenylpropanamide or the sulfonamide benzamide. And this series of drugs accelerate the formation of capsid-like particles with a normal morphology, as you can see here. Just here a list of drugs that has been evaluated in preclinical models, and many of them have been evaluated in clinical trials. It's not exhaustive because the list would change almost every month. Just to tell you that there's a lot of excitement in this area. So these drugs obviously are targeting nucleocapsid assembly, which is what is expected from the mode of action. So you see it's different from where the nucleoside analog would work. But what is interesting is that these drugs were also shown in cell culture model to prevent the formation of cccDNA in newly infected cells by preventing the disassembly of the nucleocapsid in the cell. So this may represent a dual mode of action that may be beneficial in terms of cccDNA elimination. Here, just to show you one example, because there are several drugs in clinical trials, we cannot go through all of them. Here is the drug from Assembly, that went through phase 1 trial that was just recently published in the Lancet Gastro. A nice dose-dependent effect, and then they went on to phase 2 program that were presented at AASLD a few months ago, with a very nice decline of HBV DNA when it's combined to entecavir. So you see here the entecavir monotherapy and the combination of entecavir plus the capsid modulator. And the RNA declines, almost nothing with a nuke, which is expected, and a much more profound decline with the capsid modulator, which indicates that the target engagement was confirmed. Now the real question is whether this will lead to a decrease of HBs antigens in serum and to a decrease in the pool of cccDNA in the liver, and this we don't know yet for any of these drugs, actually. So beside capsid assembly modulators, we have strategies targeting viral transcript to suppress viral protein expression. And there are several assets, either antisense oligonucleotides or small interfering RNAs or siRNAs, which went to clinical trials. So it's not only preclinical development. And you see here just one slide of the siRNA results. To make a long story short, the siRNA was developed by several companies, and most of the progress was done by Arrowhead, and now it's being developed by Janssen. And after revisiting their product at several stages, they came up with a more optimal version that is working in E-positive and E-negative patients. And you see here that with a monthly administration of the siRNA, you see a nice drop in HBs antigen, as almost 90% of patients achieve less than 100 IU per ml, and 100% of patients had more than a log decline of HBs. Now, target engagement is confirmed here because we have HBs decline. It doesn't mean that the endpoint was reached, because here the siRNA is targeting the S transcript, so it's really a target engagement. Now the endpoint would be a decrease in the pool of cccDNA, and that we still don't know yet. There are antisense oligonucleotides that are being developed here by GSK that was presented at AASLD earlier several weeks ago. And here, just to show you one of the trial, where you see here in this phase 2 trial, the antisense administration could lead to a decrease in HBs antigen level. So again, the target engagement was shown. Now we'll have to see whether this results in a decline of the cccDNA pool over long-term administration. There are options for triple therapy, and there are first studies shown at AASLD with combining nucleoside analog, capsid inhibitors, and siRNA. So 3 modes of action. And obviously, this is just proof of concept studies, and you see here the HBV DNA decline was expected with combining all these 3 drugs. And here you see the decline in HBs antigen in a few weeks by more than a log in E-positive and E-negative patients. So now we'll have to see whether a longer-term administration of this triple therapy will lead to HBs antigen loss, and whether this will be a durable loss over time. The last family of drug is nucleic acid polymers. They are supposed to block subviral particle release, and they were shown in combination with tenofovir and interferon to decrease significantly HBs antigen level in approximately 50% of patients who could achieve a functional cure, even with some anti-S seroconversion. And this was associated with ALT elevation. Now we have to see what all this means, whether this is immune activation or is this linked to some liver damage. So this will be sorted out in future trials. Now, when you look at the novel, the landscape of novel therapies, here just a selection of drugs that are being investigated in humans. You see quite a good series of drugs that are direct antivirals, but also immune modulators. So I don't want to go in that part because this will be, it's more an introduction for the next talks. So we are in a stage where we are at the crossroad of several approaches. And now the question is whether this combining direct-acting antivirals will be sufficient to achieve a sustained HBs antigen loss or even a decline, significant decline of cccDNA, or will we need to have strategies to restore immune responses to combat the virus? And the real question is whether this combination of antivirals will be a prerequisite to modify the liver microenvironment to make it more prone to immune stimulation in combination strategies. Obviously, the holy grail would be to eradicate cccDNA directly, but this is really very ambitious. However, there's one group, the Roche group, was shown at EASL again last year, that one of their drugs could decrease cccDNA levels in primary human hepatocytes and could induce HBV DNA decline and HBs antigen decline in a mouse model. So this is obviously a preclinical model. There's still a lot of work ahead of us to see whether this drug will make it in the clinic. Now, to conclude, curing HBV infections with direct antivirals, I think it is doable, but this is really challenging. Whether we are using strategies based on pre- and post-cccDNA targets, even more challenging if we are talking about direct targeting of cccDNA. But the real question, I think, to me, is that since we will make improvement in that direction, we will decrease cccDNA level. I'm pretty sure of it. Now, whether this will be sufficient or will we need combination with immunomodulatory approaches, and whether this strategy is decreasing viral antigen expression may represent the backbone for future combination is really the main question to drive the development of new antiviral treatments in the future. I would like to thank my collaborators in Lyon and all the network of collaborators worldwide. Thank you for your attention.